Chapter 32, Toxicological Emergencies. This is a heck of a chapter. It's kind of a big one. There's quite a few objectives, quite a few items to cover. However, I'll have to say congratulations. You guys have made it to the end of medical emergencies. So once we complete this chapter, we obviously will be ready for the section exam or the block exam. Chapter 32 it's a good way to end off on this. There's a lot of great information. I really kind of like this chapter, other than it being very, very long with a very, very long presentation that goes with it. We've really kind of conquered now the next to the last complex and difficult section of the book. There's one more section that the book looks at as a separate section, but the OB, Peds, Geriatric, special patient population is kind of a difficult and intense section. However, we couple that with ambulance operations, which is pretty simple, really a piece of cake. So kind of you get a little give and a little take there. Next section we have is traumatic emergencies, which to me is rather boring, simply for the fact that you try to stop the bleeding. Air goes in and out, blood goes round and round. Any variation is a bad thing, and so trauma is usually pretty simple. You kind of coast through that, and we're already looking at the end of the course in sight here. So, as with all chapters, you must read and study the textbook, not only view and listen to the lectures. They are helpful, but they are also supplementary. Hopefully the last time we're going to see this for at least a while. The Advanced EMT applies fundamental knowledge to provide basic and selected advanced emergency care transportation based on the assessment findings for an acutely ill patient. There is a multimedia video on cocaine. We have a whole bunch of objectives, and those objectives cover pages 726, 27, and 28 in your textbook. So quite a few of those there, somewhere about 13 slides worth. So our introduction to toxicology. Exposure to toxins, whether they be accidental or intentional, are a common reason for emergency medical care. Usually when we're talking about things such as pediatric population, we're looking at accidental poisonings. When we're talking about the adult populations, particularly the young adult populations, we're probably looking more at what is not an intentional overdose, although it may have been an intentional use of a substance. Of course, we also have a lot of potential hazmat situations, which would be, in most cases, accidental. We also deal with those that are intentionally making hazmat situations as acts of terrorism, or those that are intentionally creating a situation that becomes a hazmat situation for monetary gain by cooking their own drugs. And then, of course, we also have accidental overdoses in the more senior populations as well. The majority of toxic exposures are unintentional. The intentional poisonings, the majority of those are suicide attempts and poisoning deaths. So an intentional exposure is abuse or misuse of a substance and the mechanism of intentionally harming oneself or another person. So when we have that intentional exposure, we maybe are trying to get a little bit of a high off of that. So in 2009, there was estimated 2.5 million poisonings that consulted the Poison Control Center. It's really truly hard to say how many truly happened that didn't get put at the Poison Control Center. 65% of those were in patients under the age of 20, so the greatest majority there. However, the greatest proportion of fatal exposures were in the 40 to 49-year-old age group. So and the vast majority of the toxic exposures, 82%, were unintentional. So these unintentional exposures, these accidental exposures, therapeutic errors, which we very well could make, and we have occupational and environmental exposures as well. So there's lots of potential ways that we come into contact with these things. We might be talking things such as insects or animals. We might be talking medications, maybe talking illicit drugs, the hazmat situation. Sometimes it's a hazmat situation that was unintended. So let's say farmers that are out spraying. So we've got just so many potential ways that this can happen. Even things like carbon monoxide exposure are technically a toxicologic emergency. So some of our common substances we run into, analgesics, people taking a little too much pain medication, because those tend to be the ones that are not over-the-counter, non-scheduled meds, tend to have a little bit more powerful kick to them, and of course, being that they are scheduled medications, have an addiction potential. We have personal and household substances. I know of many situations in which people, particularly young people, wanted to do some cleaning around the house, or were asked to do some cleaning around the house. Most of the time they don't want to, but we're going to do some cleaning around the house, and they're like, how am I going to clean this up and do a great job? And they mix a couple of chemicals together thinking that it's going to do a real good job of cleaning up, and what do you know, it happens to be ammonia and bleach, which creates a very toxic, potentially lethal gas. So that sort of thing happens. Sedative-hypnotic agents. So people trying to get a good night's sleep. Maybe we'll have a little glass of booze here, and take a couple Valium, try to get us to settle down. Pesticides, particularly more in the agricultural setting, but certainly we can have some pesticides around the house that cause a few issues. There have been some people who have done some pretty stupid things when it comes to pesticides. I know that there was a time in which Poison Control received a call that a mother had found her child out in the yard eating ants. So a small child out in the yard eating ants, which concerned her very greatly, so she promptly took him in and gave him a dose of ant killer in order to kill the ants that were in his body, and then she called Poison Control to see if there's anything else she should do about these ants. Once she told him that she had given him some ant killer, they proceeded to tell her, go ahead and now take him to the ER immediately. He probably would have been just fine with the ants, but with the addition of the organophosphate poisoning from the ant killer, also has the potential to kill the little boy. And then antidepressants a lot of times. Our fatal exposures tend to be the sedative drugs, and the opioids. Those are the ones that tend to really depress the respiratory drive. Cardiovascular drugs, because they can just a little bit go such a long ways in most cases, where a person maybe has forgotten that they've taken their medication for the day and take it again. Even sometimes 1 or 2 extra pills is just enough. Acetaminophen, people abuse the crap out of it, eat it like it's going out of style, and that can have some pretty detrimental effects to our body. Antidepressants, people that are typically depressed to begin with are more likely to have some sort of a suicidal ideation. Anticonvulsants, because those are going to be extreme depressants as well. Alcohol is a depressant. Stimulants can make your heart jump into overdrive. And then, of course, street drugs. Amongst the pediatric population, we see analgesics, because they can get their hands onto those, and people aren't real good about always keeping child-proof caps on them because they think that they're pretty safe. Batteries, particularly things like button batteries, they'll eat a button battery, and that button battery actually starts to dissolve their stomach, causes major issues on the inside. Hydrocarbons like gasoline, certain plants, cough and cold preparations. That goes with your case study. So toxicology is the study of poisoning. So basically prescription and illegal drugs, plant, animal, and other toxins. So there's a whole medical specialty related to toxicology. Most of the substances can be grouped into families with similar properties, and those similar properties can then be assigned a toxidrome. And that toxidrome is kind of what you see when people have this type of poisoning or this type of overdose. Some examples of the toxins that fall within that, and then the treatments that are generally given to that. So when people call a poison control center, most of the time poison control center will send them information that is related to the specific toxidrome that goes with that, as opposed to them sending a sheet for every single substance that a person may take. They'll often give them the toxidrome sheet, and it'll give them the general treatments to go along with that. Poison control has at a fingertip so many potential resources that they can access almost immediately and get that into the hands of the healthcare providers. It would be nearly impossible for every healthcare facility to have the resources available that the Poison Control Center does. We would have to have separate rooms of books and whatnot. Now things have become a little easier with some technology, because technology makes it easy to store lots and lots of information. The World Wide Web has created some great resources that people can use to research many of these different toxicologic events. But still, to have it at hand and have people who specialize in assessing and treating people with toxic exposures is an invaluable resource. So we have just a handful of selected toxidromes here in the text. We're going to look at these over the next couple of slides. It gives you an idea of what a toxidrome really looks like, and then it also gives you some examples of the major families that we may be dealing with. So the first one we look at is the cholinergic agents. So these stimulate the parasympathetic nervous system. So remember, cholinergic can also be a parasympathomimetic or a pro-parasympathetic. So some examples would be the betel nut. So that's a nut, contains various stimulants that stain the teeth red. We have things like bethanechol, which is a medication for difficulty in urinating. Carbacols, used for the treatment of glaucoma. Muscarine, which is found in poisonous mushrooms. Pilocarpine, it's used to treat dry mouth. Jaborandi, which is a species of plant used in homeopathic medication, and various organophosphate pesticides such as diazinon and trithion. So it gives us a nice wide grouping there. So it talks about maybe some plant products, some medication products, some things that are maybe used from a homeopathic standpoint, and then other products around the house that we may find. The cholinergic toxidrome tends to have things that will cause you to secrete. So parasympathetic, when we overstimulate the parasympathetic, if you're able to produce liquids and fluids from it, most likely you're going to. So every one of your orifices is going to be secreting something. General signs and symptoms include feeling of warmth, tachycardia, occasionally bradycardia, sweating, constriction of the pupils, increased salivation, blurred vision, confusion, urinary incontinence, and diarrhea. It can cause bronchoconstriction and increase in bronchial secretions, and a great way to remember a lot of these things is sludge M. They don't include the M on this one, but sludge M. So salivation, lacrimation, urination, or urinary incontinence, diarrhea, gastric distress, emesis, and meiosis, which is the constriction of the pupils. Airway management is going to be critical in the treatment for this because there's going to be salivation and emesis. In most cases, if you have the Mark 1 kits on your truck or duodotes on your truck, if you're going to be treating yourself or your coworkers, that's the treatment of choice for them. Depending on what your protocol is, you may also be able to deliver it to patients with organophosphate poisoning. And that Mark 1 kit or the duodote has the drug atropine and the drug pralidoxime or Tupam. That's used to help with that bronchospasm. We may also use bronchodilators. The atropine will help dry things up. So it's kind of an ugly, ugly situation. The anticholinergic agents, so this is going to inhibit parasympathetic and allows for increase in sympathetic nervous system. So it's sympathomimetic. So things like the belladonna alkaloid, atropine, scopolamine, Jimson weed, amanita mushrooms, let's see, donatol, which gets used for intestinal cramping, black nightshade, tricyclic antidepressants that I mentioned in the previous chapter, phenothiazines, antihistamines. These all have anticholinergic effects. So they're intended to dry you up, basically. So these are going to show up as things like dry skin and mucous membranes. They're going to be flushed. You're going to have hyperthermia because it kind of kicks your metabolism kind of into an overdrive state. Gives you some blurred vision, dilated pupils, urinary retention, delirium, ataxia, seizures are all possibilities. And a good way to remember this one, the anticholinergics, is mad as a hatter, dry as a bone, red as a beet, and blind as a bat, hot as hell. It's because it tends to make you have some very odd behaviors, dries you out, as opposed to the cholinergic agents, which made you really wet. Red as a beet, because you're spiking up a hyperthermia, your blood pressure is usually going up, heart rate's probably going up, you're dilating. Your vessels, blind as a bat, because of the dilation of the pupils makes it hard for you to focus, and hot as hell because you have the fever. This is mainly a supportive treatment, so O2, airway management, some IV fluids. Remember, they're dry, so we're going to try to give them a little fluid to kind of counterbalance that. You can certainly call for paramedics in this situation. You may have some seizures, in which is going to require, any of these really, you can call for paramedics. They may or may not have an antidote, but they may have additional supportive cares that they can do. So, sympathomimetic, which stimulates the sympathetic nervous system. So we have an overdose specifically of a lot of beta stimulant, and we have caffeine, cocaine, amphetamines, ephedra. These all cause excitement, seizures, tachycardia, hypertension, potentially some chest pain and cardiac dysrhythmias. Can cause an MI, so it can be that severe, cause people to have a stroke. A lot of this is mainly supportive care. You need to try to cool them down in some situations because they could be hyperthermic. Some other things is a lot of times at the paramedic level, these people may also receive a sedative drug like Valium to just try to bring things down a little bit, kind of try to offset some of that over-the-top CNS stimulation with a little CNS depression. The narcotic or the opioid toxidrome. Remember, narcotic has been bastardized. In most cases, when people say narcotics, they don't truly mean opioids, which is what narcotic actually means. Narcotics has been bastardized and now means illicit drugs or illegal drugs. But in the true medical sense, narcotics, these bind with the CNS opiate receptors and cause CNS depression. These are painkiller agents. So heroin, morphine, codeine, hydromorphone, which is Dilaudid, hydrocodone, oxycodone, propoxyphene, opium, fentanyl, meperidine, which is Demerol, All of those are common substances in the opioid category. They cause sinus depression, they cause respiratory depression, pinpoint pupils, one of the very few drug classes that and substance classes that does this, and hypotension, mainly supportive care, ABCs, start an IV, and naloxone. So Narcan comes into play here. Remember that Narcan is used, we use it a little bit on the reserved side. We're simply trying to bring them up so respiratory depression is resolved. We don't often know why they're using such a substance. If they're using it chronically, we could bring them all the way up by giving them 2 or 3 or 4 or 6 milligrams, and next thing you know, the patient is in withdrawals, and we're doing kung fu fighting in the back of the ambulance. So you got to be cautious with that. Remember, it's enough to bring the respirations back. Another typical toxidrome is the extrapyramidals. The extrapyramidal tracts of the nervous system are involved in a lot of our motor control. Antipsychotic drugs often have these extrapyramidal side effects. It's not their intention, but something that they do as a adverse effect. So Haldol, droperidol, chlorpromazine, those are all antipsychotics. Some of the antiemetics that we use to keep people from yakking all over the place, things like chlorpromazine, or not chlorpromazine, well, chlorpromazine is already listed there. Things like compazine have these effects. So causes muscle spasms and rigidities and tremors, an oculogyrate crisis where their eyes are just moving constantly around, torticollis where their neck starts to spasm and their head tries to spin around like in The Exorcist, neuroleptic malignant syndrome. So a lot of things that affect their nervous system are affected by these extrapyramidal drugs. And most of them are supportive cares again. We can have acute dystonic reactions, which we can reverse with diphenhydramine. So if you have a patient that's alert, oriented, able to swallow a pill, and you carry over-the-counter Benadryl and have permission either via protocol or online medical control to administer it, you could probably give them some of that and would help to start bringing them down. Remember, it's going to take a little while because it has to be absorbed orally, but we have the potential, one of the potential treatments right there. So, and then treat their hyperpyrexia. They're going to develop some sort of a fever as well. So maybe aspirin or ibuprofen as appropriate. We can use those to help kind of fight off some of that fever. We typically have 4 toxin routes that things get into our body: ingestion, inhalation, absorption, and injection. Probably the more common ones are going to include ingestion and inhalation, although injection certainly is a possibility, particularly in the drug abuse world. Note, though, that not all drugs of abuse are injected. Huffing is a huge deal. Huffing, where people are inhaling substances with some sort of an intoxicant in them. Those are not injected. Many of your over-the-counter agents, some of the cough medicines, have become drugs of abuse. The people who are abusing prescription drugs, those would not typically be injected. So we've got lots of potentials there. Ingested substances are swallowed. So these could be plants, medications, alcohols, drugs, household substances. Substances get absorbed out of the gastrointestinal tract once they reach the stomach and the small intestine. Not that a little bit isn't going to be absorbed via the mouth, but the majority of it is going to be not until it gets into the stomach or the gastrointestinal tract, or I'm sorry, the small intestine. Inhaleds, these are fumes or gases that can cause tissue damage on contact with the respiratory mucosa. and they can cross, in many cases, cross the respiratory membrane to exert their effects as well. These are quick highs, so people who are huffing stuff have an almost immediate intoxication, whereas people who are ingesting stuff, it's going to take 10, 15, 20 minutes for the effects to start. All right, many toxins cause damage directly to the skin and the mucous membranes and can get absorbed through them and enter the bloodstream and cause systemic effects. This is probably the slowest route that most of the substances are going to get into our body. We know that the closer you get actually to the central circulation, the longer it takes for it to actually take effect. And if it has to enter the bloodstream via absorption, it's then going to get processed by the liver. So it obviously is going to take a little bit of time. Injection, on the other hand, is generally pretty quick. If it happens to be injected intravenously, that is the quickest route of onset for many of our substances. So just like some of the medications we give IV are very, very quick acting, same is true with those people that are using substances or abusing substances. So whereas if we inject it subcutaneously or IM, it's going to take a little bit longer, but still pretty quick. And then these toxins can have either just localized effects, which we're kind of looking at. If you would have a minor allergic reaction, would be very similar. So you have a little breakout in an area in which you came into contact with a substance, or you can have a major systemic event where it takes over, kind of like an anaphylaxis. So there's roughly 60 poison control centers throughout the United States and the territories. They are staffed 24 hours a day by specialists in medical toxicology. Now, you may not actually be talking to a toxicology physician, but there's usually one immediately available. So if you might be talking to, say, nurse specialists or other medical scientists who have studied medical toxicology, the toll-free national number, in case you can't remember, is actually pretty easy. It's 1-800-222-1222. So it's 3 2s, a 1, and 3 2s. And then determine the severity of the exposure. They're going to try to help you figure that out. They're going to suggest how to start managing the exposures to specific toxins. You can call them from the field. You can call them from the field, and usually if you're able to work with them a little bit, they can even get some information and data sent to the receiving hospital so they can be prepared by the time you guys get there with your poisoning patient. So being able to use poison control can be a huge advantage. Toxins can have a number of effects, depends on their nature. Some of them are just really more of an irritant. Others will have a large systemic effect. Some of them affect only certain body systems. Some affect the whole body. Some of them will just start ripping the body apart from every particular angle. Don't forget that in many cases we're also talking about things that are hazardous to us. So we have to be particularly cautious. We have to use appropriate PPE, personal protective equipment, which is not only BSI. Well, we often say BSI, meaning PPE, but BSI is things like exam gloves and eye protection and a face mask to protect us from the patient's substances. But don't forget, PPE is a much broader category. It's anything that you use to protect yourself. Bunker gear, helmets, things like breathing apparatus, special hazmat suits, all fall into the PPE category. So you yourself do not get an increased exposure and an increased likelihood of succumbing to this substance. In many cases, the toxicological emergency can be unknown. Sometimes it's clear, sometimes people know right off the bat, sometimes it's disguised as something else. Sometimes people do a very good job of trying to hide their substance abuses, and sometimes somebody comes stumbling in the house and nobody really knows what's going on. So you're going to have to be able to start to recognize certain behaviors, certain injury patterns, certain illness patterns, and then trying to relate those signs and symptoms that you're seeing to things that you already know. So perhaps the certain toxidromes that you've already discussed, toxidromes that you're familiar with. Yes, there are always going to be things that we just don't know, but the more likely we are to stumble on something by putting together these pieces, the better chances that our patients are going to have. So scene size up, early identification of the hazard. That includes lots of things that you guys have already learned throughout the course and throughout your careers in EMS. Everybody in here needs to have training in hazardous materials awareness. That is a requirement. So if you have not completed a hazardous materials awareness course, we have an online version for you, as well as the if you're able to produce your proof that you've taken that course, that get you out of taking that extra little course. But you need to be able to identify the hazards. So that uses things like the Orange Book and a pair of binoculars, or an online resource to look up placards, and simple things like identifying clouds, plumes, and spills that have the potential to be dangerous. When we are trained at the hazardous materials awareness level, basically what that is saying is we're taught that, hey, this looks dangerous and I should stay out of it. And who should I call? That's really the extent of what the hazmat awareness is all about. So when we have something that we come across and we're like, whoa, this doesn't look quite right, we know to back off and then get ourselves some additional help. We may be asked to do things such as help secure the area to evacuate people, but for the most part, the extent of our work is done once we have identified this as a potential. We may have additional education and additional training to do other levels of hazardous materials. There's operations, there's technicians, and so on and so forth. But for the most part, EMS is on scene to take care of patients. So we're not cleaning things up. In most cases, we're not even doing decontamination. We may work with some decon on the very end of the line, where they've gone from gross decon into more fine or more specific and detailed decon before transportation. But that's all going to depend on our system. So additional resources that we need to consider when we define this as a potential toxicologic emergency of we'll say of a large scale. If we're talking, we're walking into a patient's house where we've had somebody who's overdosed on a bottle of pills, that's not going to require nearly the response that something that an overturned train car that's leaking stuff is going to require. So things to consider: law enforcement. Law enforcement's always a good idea. Number one, it helps to control the scene. Two, if there needs to be criminal investigation involved. And three, for protection, should we end up getting into a sticky situation with a patient who's intentionally overdosed. The fire department. Most fire departments are set up at the hazardous materials operations level, where basically they're designed to determine what's going on or get a good idea of what's going on, and then start to implement some strategies to prevent it from getting any worse. They're not usually intended to be technicians, which technicians, there may be people on the department that are technicians, but most of the time technicians are found on specialized hazmat units. The technicians are the ones that are tasked with starting the cleanup process. And then there are also other specialized services, big companies that come out of some of the even larger cities such as Kansas City that do the very specialized cleanup process where they have to remove dirt and so on and so forth, barrel it up and take it away for storage. So there you have both hazmat and fire department. Search and rescue, maybe a branch of a specific fire department or a specific rescue department, maybe a standalone service, but search and rescue is often geared towards a variety of settings and looking for the missing people and victims. We may need additional transport units. We may need aeromedical support. We may need something real big. Maybe we have a large exposure at a school or something along those lines. We may want to start asking for school buses to transport people. A lot of it really depends on your department and what resources it has available and how is your system designed. If we have an intentional poisoning or an overdose, substance abuse often will go hand in hand with violent behavior. So if we've gotten in there, maybe we got there too soon, they didn't want to be found, maybe we got there the wrong time during their intoxication. Sometimes they were drunk to begin with, and now they start to abuse some other substances. It increases our risk for violent behavior. Again, it kind of goes back with our use of naloxone in our heroin overdose or our opioid overdose, where if we bring them up too much, then we end up having some violence on our hands. So it's always nice to have them a little bit more snowed until we need them to be more conscious. So trying to take them from completely unresponsive to alert and oriented most likely is not going to happen without a little bit of a fuss in the middle of it. So during our scene size up, we're going to look for things such as multiple patients. Now maybe we didn't get called for multiple patients. Maybe we didn't get called for a toxicologic emergency. Maybe we got called for a sick party. Somebody has a headache, nausea, and vomiting. It's early in the fall, just getting a little cool and crisp out, and somebody just has some quote-unquote flu-like symptoms. And we show up, and the whole family has flu-like symptoms. Well, in general, people don't go from everybody was healthy to now everybody's sick all at once, unless there was a large event, a large item that occurred that has caused everybody to be exposed to something. If you're passing around an illness in your family, it's usually not the entire family sick at the same time at the same level. Somebody's getting over it, somebody's is catching it, somebody's getting worse while somebody's getting better. So if we would show up and we have all these sick people, all roughly about the same area, all about the same stage of the illness, that's got to be a trigger. It's got to say, hey, something's not right here. Do we have a carbon monoxide leak? Did everybody have a food poisoning? We got to look a little closer. Look for unusual odors, unusual vapors, clouds. Look for spills of certain substances. Look for various behavioral emergencies. Are people acting out? We gave you a good example of the anticholinergic toxidrome where the patient was mad as a hatter. Do we have alteration in mental status? Most toxic substances are going to alter the mental status. If it's available, look for things that will identify the substance or substances. Sometimes that's not our duty. Sometimes if we're dealing with, say, a hazardous materials incident, we're not going to enter that scene to go get that. We may try to get an idea with our binoculars and our orange book and reading the placard, seeing what the number is on the placard, and trying to identify a class, but we're not going to dive into that. We have a single person that is ill from an overdose, and it just so happens that they've overdosed on some prescription meds, that makes it probably a little easier. Or we have a child that's drank something from under the sink. It probably makes it a little easier for us to identify. The quantity involved when possible. Sometimes you have to be a little resourceful. So you got to ask people, how much was in this container? Oh, well, I just bought it. It was brand new, and now it's empty. You pick up the pill bottles, and you see, well, I see that this was a month's supply of medication. You filled this yesterday, and it's now empty, or it's half empty. You can pretty much guesstimate how many pills are remaining in there and say, well, that's going to give us an idea of the potential scope of this. No, we're not always right. Sometimes people are wanting the attention. Maybe they dumped a bottle of pills down the toilet, but took a couple of them. But it made it look like it was much worse than it actually was. But it gives you an idea. Time of exposure. Sometimes we know that this has been a very quick thing, and sometimes it remains a mystery. So we show up at that house at 8 o'clock in the morning when everybody's ill. We don't know when the carbon monoxide started leaking, but if we know that they were all fine the night before when they went to bed, we have a range. The patient's weight. Remember, weight is very important when it comes to toxicology and poisonings, because there's usually determined by the lethal dose is usually determined by body weight. So somebody takes a pill, one pill. A 220-pound, 6-foot-tall person takes one pill. It's probably not going to have nearly the effect as it is on a 2-year-old that weighs 30 pounds. And then what has been attempted in treatment of the patient prior to your arrival? How long ago did we remove them from the environment? Did we try to give them anything to counteract this? Was there any antidote available that was already given to them? There's more and more law enforcement push for the use of Narcan by law enforcement officers, because Narcan can be given in the intranasal route. We can put a little, what's called an atomizer, on the end of the syringe, and it turns the Narcan into a very fine mist that we shoot up their nose, and it's actually picked up almost as quickly and as effectively as IV medications are. So maybe that had been done prior to your arrival. Maybe somebody gave them syrup of Ipecac or gave them activated charcoal because they had it around the house. It's an over-the-counter medication. Milk is another one. If relevant, what is the duration of the exposure? Do we know if they were exposed for 30 seconds or 5 minutes or 3 days or what? Any label information? If we can transport the container safely with us to the hospital, we should do that. Sometimes it's not reasonable or prudent to do that. Perhaps just the vapors alone are going to cause illness, and in those cases, don't stick it in the ambulance. You're just going to get everybody else sick. Maybe you can get a shot of the label on a cell phone, and with that picture, then we can identify more information. But if it's something that we can pick up a couple of pill bottles, or we can take a container of household cleaner which isn't leaking with us to the hospital, we should do that. Use things such as your DOT Emergency Response Guidebook or the Orange Book. Everybody should be familiar with that one. Or an MSDS. If you are going to a place of business, every business that has any potential toxic chemical in it is supposed to have a material safety data sheet. Now, from what I understand, there's a kind of a worldwide push to change those MSDS sheets to a little bit of a different format, but we currently have the MSDS sheets, or are supposed to have them available 24 hours a day to anybody in that facility, so they can't be locked up in the chief executive officer's office. They have to be available 24 hours a day in case somebody would be injured or exposed to one of those substances. So maybe they already have the MSDS sheet handy for that chemical, and so you can grab that, and it has a lot of the same information that the Orange Book has in it. Identify the potential for polysubstance overdoses. Not always is this obvious, but if you show up at this house and there's several open pill bottles and several open bottles of alcohol, and maybe there's a baggie of marijuana, understand that we have really compounded this problem, and it's going to be probably very difficult to sort out exactly what it is that is causing so many problems in our patient. Maybe it's everything, maybe it's only one thing, but identifying the potential can be a critical and crucial step in the assessment. So in our primary assessment, obviously looking for CNS depressants. CNS depressants can impair our gag reflex. It can cause unresponsiveness, it can cause airway obstruction, it can depress the respiratory drive, eventually can also depress the cardiovascular system. Most of the time, cardiovascular effects come from the failing respiratory side of things, but not always. Vomiting with exposure to many toxins jeopardizes the airway. So many of these toxins may cause some sedation. The person vomits, and then that vomit then gets sucked in to the patient's lungs, and they now have an aspiration issue. Some of those toxins cause soft tissue damage of the upper airway, so it can burn. If it gets burned on the way down, chances are good it's going to burn on the way up. So if they vomit, you just double whammied them. Some things will cause pulmonary edema. Superheated gas. Somebody was in a house fire. They may inhale some of these agents into their lungs, and with that, this superheated gas can cause some burning, which is going to cause pulmonary edema. We're going to check their breath sounds early, and we're going to reassess them on a regular basis. So we're going to keep our eyes on any potentially developing pulmonary edema. A lot of toxins can cause vasodilation or can impair cardiac output, reducing our perfusion. So we may have to consider some fluid therapy. And then we have to constantly be reassessing ABCs. These are some of the patients that have some of the most dramatic turnarounds, and usually, or actually I shouldn't say turnarounds, some of the most dramatic changes in their condition, because in many cases they went from being okay when we got there to being really oh crap before we get them to the hospital. Of course, if we have the unresponsive patient, we're immediately going to check a carotid pulse, start the CPR, AED sequences as necessary, maintaining their airway, ventilating as appropriate, providing high flow oxygen where necessary. And it doesn't have to only be inhaled substances that we need high flow O2. So you have to consider what are we also seeing as far as patient's skin tones. Do we see respiratory distress? Do we see hypoxia, signs of hypoxia? Do we see low saturations on the pulse ox? Things like cyanide can also be a major issue. Cyanide actually is an asphyxiant. It goes in and displaces oxygen. So those people benefit from some high flow O2. As necessary, having our suction ready to go, suctioning where appropriate. Basic and advanced airway adjuncts may be necessary, as well as manual maneuvers. If the patient currently doesn't have a need for immediate resuscitation, we may place them in the recovery position or place them in the left lateral recumbent. So if they would vomit, it can drain out of there until we can get the suction ready to go. So use the Fowler's position in conscious patients who are vomiting, so we can sit them upright if possible, provided that their other vital signs support that. So they can get that vomit out of their mouth. Oxygen as necessary, and those with the increased metabolic rate, so those people who are clipping along and hypertensive and feverish, oxygen will generally benefit them. They're going to be using it up, so it's probably going to be appropriate that we increase the amount of oxygen that's available to them. Assessing for things, signs and symptoms of shock, such as pale, cool, clammy skin, increased pulse rate, a weakened strength. Syrup of ipecac is no longer recommended. Those of us that have been around the EMS world for a while used to use syrup of ipecac in the field to induce vomiting. It produces repeated episodes of forceful vomiting, which can have some pretty negative side effects, including aspiration. They don't recommend it anymore. Anytime that we're going to remove something from someone's gut, we really strongly suggest using a tube of some sort to do what's called gastric lavage. And then remember that these are potentially people who are going to have very quick changes in their condition. With their history and their secondary, sample history is going to be critical if we can get it. Oftentimes we're left relying on bystanders, family members to gather much of that information from. Then doing the quick head-to-toe, of course, on those people that are critical, and a little bit more focused exam on those that are not so critical. And then if we're able to kind of put 2 and 2 together on the toxidrome, that also helps drive areas for us to evaluate and to look at. So what information about the exposure should you obtain? We've discussed that. So in our secondary, we're going to, of course, be gaining vital signs. Looking at your monitoring devices, particular pulse oximetry. If you have the luxury of some of the other non-invasive monitors, that's great. Maybe you can assess pulse oximetry or end-tidal CO2. You can assess things like methemoglobin. If you've been lucky enough to get, have an extra $6,000 sitting around that you can pick up a RAD 57 where you can see carbon monoxide levels in our patients. That's fantastic. There are a few other minor monitors that can get used here. Blood glucose level in anybody who's a diabetic or has an altered mental status. That's just got to be standard treatment protocol for us. Mental status is altered or you're diabetic, we'll check your sugar. Otherwise, not necessary. And then do the focused or head-to-toe exam based off of what our assessment is telling us. As far as clinical reasoning, without careful questioning and a high index of suspicion, a lot of poisonings can go undetected until that patient suddenly deteriorates. So as things aren't adding up, we need to dive in and clarify a little more. So if somebody has kind of an anxious or an altered mental status, maybe they're a little depressed, and you note that there's some evidence of something gold and sparkly around their face, you might need to question them. What's this on your face? Where did that come from? It looks like spray paint to me. What is that? And they may then finally give up to you, well, I have spray paint. So where these people typically will buy the spray paint, they get the plastic bag from the store that the store put the paint in. They'll spray it into this bag, and then they hold the bag up to their face, and they'll inhale those fumes. And oftentimes they'll get little bits of paint stuck on their face as well. So you have to be a good detective when it comes to this. And if things don't add up, ask more questions. Be careful. Don't be argumentative. Don't start to try to lay blame on anything here. But you can kind of play dumb a little bit with some of this and gather a little more information. Maybe something doesn't add up, that you have this very low energy car crash and this person is unresponsive. Well, that doesn't make sense. He's got a seatbelt on. Why is he unresponsive from a car crash? That doesn't make any sense. So we go digging a little bit more. Maybe it's a poisoning or an overdose. So patients who attempt suicide sometimes will do this with mixed methods. So I'm going to get drunk, I'm going to take a bottle of pills, and I'm going to get in my car and drive it off the road. Sometimes people are not particularly brilliant when they design these plans. As evidence from one girl that I remember picking up that decided she didn't want to live anymore. She was going to kill herself. So she went and drove her car off a road, down an embankment, hit a tree, and then of course was visibly shaken and bawling her eyes out when we got there. And I walk up to the car and I'm questioning her and talking to her. Somebody's got her C-spine. I'm like, so what's going on? She's like, I just wanted to kill myself. So I was going to crash my car, and I reached down and I pulled on her seatbelt, which she was still wearing, and asked her, did she plan on the seatbelt giving way when she was going to have her fatal event. So sometimes they don't really think about a lot of these things. So some of these types of poisonings, the presence of more than one affected patient provides a strong clue. Again, going back to those things such as carbon monoxide or a large food poisoning event. So, treatment. Removing patients from environments that are toxic. Sometimes the environment isn't toxic. In fact, most cases the environment isn't toxic. But the carbon monoxide poisoning patient, the person who fell victim to a cloud of anhydrous ammonia, those sorts of things are toxic environments that we can remove them from. Sometimes we have to remember, though, that there is going to be a decontamination process that has to occur. Otherwise, we spread this scene to our ambulance, to ourselves, and then we take the scene to the hospital with us. So decontamination is definitely something that you have to consider, at least, depending on the patient's overall situation. Again, very supportive of ABCs, oxygenation, airway management. We're going to do suctioning as necessary, manual maneuvers, basic and advanced adjuncts, CPR, AED. Probably consider starting an IV. Some of them will benefit very nicely from getting some fluids. At the very minimum, we have a drug route in case we need to give certain medications such as Narcan, and we know that naloxone is quickest to act when it's given IV, although not all of our patients are opioid overdoses. Try to minimize the amount of toxin that the patient's being exposed to. Whether we ventilate them with high flow oxygen, we have decontaminated them by removing their contaminated clothing, wash their body, clean their body. We rinse, we do a constant flushing of their eyes to remove as much toxin as possible. Most toxins, this is, I think is a hallmark slide here, most toxins do not have specific antidotes. To be honest with you, we probably have a couple dozen at best antidotes for different substances. There's not a lot of them. There's only a few, and a lot of times, even in the hospital, people have to have basically supportive therapies and hope that they come over and that they get out of this okay. Occasionally they get thrown on something like dialysis, in which they'll take their blood out and do their best to remove as many of those toxins from their blood, but in many cases it's a wait and see game. We do have a great antidote, though, for our narcotic overdoses, in which we can give naloxone. And remember, we can give that just about any stinking route that we need to. Activated charcoal, on the other hand, it is not strongly suggested anymore. Yes, you probably gave this as an EMT or an EMTB. You probably learned about activated charcoal. This day and age, the use of activated charcoal in a patient who doesn't have a controlled airway is almost completely unrecommended. There's been a large number of issues in which people have inhaled some of their activated charcoal because they were spitting and sputter, either sucking it in or when they started to vomit, lost control of their airway and aspirated some of this stuff. So activated charcoal is an adsorbent, just like you can put charcoal in your fish tank filters, you can put charcoal in your fridge. It's used to absorb toxins, chemicals, odors, so on and so forth. So the use of activated charcoal when we give it orally is only good within 1 to 2 hours after ingestion. So if that patient's laid there overnight, they overdosed at 10 p.m. and it's now 9 a.m., chances are pretty good that whatever it was that they overdosed on orally is gone. It's out of the stomach. So, and it's just going to be, we'll have activated charcoal chasing it, but never actually catching up to it because it's so far moved through the system. Activated charcoal does not work on all substances. Things such as alcohols, things that are particularly caustic, either very acid or very base. Several different types of pesticides it doesn't work on, and it's not a fix-all. Not to mention, activated charcoal is intended only for oral poisoning. Things that are inhaled, injected, absorbed, activated charcoal has no effect on. So it goes in, it's supposedly flavored, although most people will tell you that have had to drink a little activated charcoal that it doesn't go nearly far enough. And then it actually uses, it helps to move this stuff through the system and expedite it coming out the other side. So that activated charcoal hopefully absorbs that chemical and then expedites its way out the back door. And but again, it is for the most part out of favor for use in the field setting. So even a lot of paramedic services are no longer carrying activated charcoal. And Poison Control Center can give you lots of good information on whether or not there is an antidote, whether or not activated charcoal is appropriate or not, and they can kind of give you some guidance to ask some more appropriate questions about what's going on. One example of activated charcoal, Actidose aqua, other names for it, Actidose with sorbitol. Sorbitol is just another agent that goes in there and helps flavor and cause it to move on out, assist with the absorption. So, during reassessment, the level of the toxin in the patient's system can be increasing as we assess. So if they took the pills 2 minutes before somebody called 911, it took us 7 minutes to get there. We've been on scene now for 5 minutes doing an assessment. That puts us easily at about the 15-minute mark, and that's about the beginnings of when we start to see patients have effects from oral ingestion of certain drugs and other substances. So we can very quickly see them deteriorate and change. So our reassessment includes all of our basic initial or primary assessment information, treatments that we've done, any specific complaints, and any specific areas that we've found issues on our assessment earlier. If you suspect a narcotic overdose and you have respiratory depression, manage the airway carefully, and administer Narcan or naloxone to increase the level of consciousness just slightly to the point in which they can have an improvement in their airway and their respiratory drive. Do not attempt to wake them all the way up. So if the patient has an airway device, such as in the oropharynx or the trachea, it can cause gagging, vomiting, distress, or injury. So if we show up, we decide we're going to be very aggressive in our airway management, we slam a king airway down them, and now next thing you know, we're going to go ahead and start an IV, and we're going to give them some Narcan. It's very possible that now we're going to have to deal with the consequences of there being a tube down this person's throat, and we're going to have to manage their vomiting and their retching and their fighting us. All right, carbon monoxide. Carbon monoxide is a colorless and odorless gas. It comes from incomplete combustion of fossil fuels, basically. So petroleum products, wood, carbon, so on and so forth. It's very dangerous in enclosed spaces. Luckily, it's a very minimal part of our environment. It's very fractional in our inhaled air, so we don't usually have to deal too much with it. But when it can't freely circulate and get pushed out into the open atmosphere, it builds up. And once it's inhaled, carbon monoxide quickly pulls across that respiratory membrane, binds with the hemoglobin about 200 times faster than oxygen. So basically what it does, it gets in there and it takes up the space where oxygen should be, and it makes it harder for oxygen to latch on and do its job. Common complaints that go with this are headache and dizziness, confusion and sleepiness, and vomiting. Note that cherry red skin and lips is not on there early in this process, simply for the fact that it is a very late sign. Additionally, they may complain of being shortness of breath or being short of breath because their body knows, hey, I'm not getting enough oxygen. How do we improve this system? Let's just breathe faster. General malaise, so they're tired and they're weak. Tachycardia and tachypnea, body's doing what it can to offset the lack of oxygen. They're hyperthermic in many cases, and they're agitated because their body is working extra hard to try to compensate. Judgment and memory problems. Signs of symptoms of the most severe poisonings include chest pain, severe confusion or unresponsiveness, ataxia, or basically unable to hold themselves upright, seizures, rhabdomyolysis, which we may not necessarily know, that cherry red skin tones, particularly to the lips, renal failure. It is our job to try to identify the hazard. You yourself are probably not going to immediately suffer any of the signs or symptoms of carbon monoxide poisoning. It's not like you walk in the house and are instantly hit with it. It takes a couple of minutes for it to kind of start. So if you're in that environment unprotected for really any amount of time, you run the risk of exposure there. Some of the best things to do if we have to go into these environments, it's better to have somebody with PPE, with a breathing apparatus, go in, remove these patients, bring them outside, and treat them outside where it's not going to be such a concentrated environment. If you have to go in, start opening windows, start opening doors, get as much air going as possible, and shut off the furnace or whatever else. Maybe it's a different type of heater. Extinguish that in order to stop pumping out more and more CO. So activate your appropriate resources. There's probably going to need to be a gas company come out and take a look at the furnace. That typically is the biggest cause. Remove them from the source. Maintain their ABCs. In many cases, we need to probably ventilate a little bit. A little forceful ventilation helps to displace some of that CO and get some oxygen on board. High flow oxygen, even though, in this case, even though their pulse ox might say 100%, 99%, still high flow O2. And the reason for that is actually your pulse oximeter tells you how much of your hemoglobin has a gas attached to it. There's not a lot of gases that do attach to it, but carbon monoxide, like I said, attaches 200 times faster than oxygen. So your pulse oximeter is going to read 99, 100% because there's all this carbon monoxide in there in the place of the oxygen. Your pulse ox can't tell what gas that is. It just knows that there is a gas. Be prepared to deal with vomiting. So all patients with this potential for carbon monoxide exposure get the non-rebreather. Oxygen, high flow O2 reduces the half-life of CO. And in some cases, hyperbaric chamber, hyperbaric oxygen reduces the half-life dramatically. So the hyperbaric chamber is basically compressing a patient in a tube and dissolving, making a lot of those air bubbles much smaller, and in turn those air bubbles are easily transported out of the body. So in the Omaha metro area, the hyperbaric chamber of choice is the Nebraska Medical Center and the Clarkson Tower. There's a few other hospitals that have smaller units that are really more intended for wound therapy. And then start an IV, give them some fluid. They're potentially going to be hypotensive. All right. So the most important actions in the management of a poisoning patient include recognition, scene safety, and then minimizing their exposures and being very supportive. So the supportive cares. Okay, cyanide. Cyanide is found in several products or items. It's very prevalent in house fires as a result of combustion of many of the materials that are commonly found in house fires. Another place that cyanide is found is in the pits and seeds of most fruits contain a little bit of cyanide. So it takes more than swallowing one or two seeds in order for it to be a major problem. But it is present there. It is possible for you to start to get ill from that. It is a cellular asphyxiant, which means it stops the energy production at the cellular level. It keeps the mitochondria from processing the oxygen, and that results in an anaerobic metabolism. Death generally occurs within seconds to minutes after ingestion or inhalation. There are a number of treatment kits that are out there on the market. I've never seen one used, mostly because people who are suffering from cyanide poisoning generally don't make it that far. So be strong suspect of patients in a house fire or a working structure fire. The common complaints include weakness, malaise, headache, dizziness, confusion, seizures, and shortness of breath. Not to mention they may also have some pulmonary edema, maybe in a coma. They may have an odor of a bitter almond on their breath. The problem with this is that we don't, a certain degree of the population can't smell that odor anyway. So it becomes a less than reliable sign for us. And then their pulse oximeter may also be very high. They may have some signs or symptoms of hypoxia and acidosis. All of these are, I think, general enough that it is very difficult for us to know whether or not cyanide is an issue here. Unless we smell that bitter almond on their breath, we really don't have a lot of very specific indicators here. So the signs and symptoms are going to be managed supportively with ABCs, high flow O2, ventilation as necessary. If they have pulmonary edema, ventilation can be very beneficial. Activated charcoal can be indicated if they have ingested cyanide, although remember we're probably talking about somebody who's going to have a quickly diving altered mental status, so they may not even be able to ingest the activated charcoal. So you should consult with your medical direction on cyanide poisonings, of course. There is an antidote kit, a couple of different types of kits out there. There is hydroxycobalamin, which is vitamin B12, and then there's also a 3-part cyanide antidote kit with amyl nitrate, sodium nitrite, sodium thiosulfate, some of which are intended to be inhaled and some of which are intended to be injected. It's not within your scope, but it might be something that either the paramedics would give, although I don't know of any ambulances that carry it, or it would be something they would be given in the ER. And I've seen plenty of antidote kits in the ER sit and draw dust because there's just simply so little use for it. It's so rarely used. So consider it if we're trying to rehab a firefighter. We have somebody who has been in a house fire, maybe he's gotten a little bit winded. We would want to give at least some consideration to both carbon monoxide and cyanide amongst several other ugly caustic gases, phosgene and whatnot. So if we're having complaints of chest pain, dizziness, shortness of breath, in many cases we got to consider that it's toxic inhalation. They may have other general complaints, aches, pains, cramps. They're probably going to get either a heat or cold related emergency on top of it. Seems like it's either too hot or too cold to fight a fire. So I've spent plenty of days out on structure fires doing standbys, in which it has been ridiculously cold and windy. And then a number of them that have been pretty warm. But for us, it wasn't particularly hot. But once you take into account the amount of gear that a firefighter wears, and then the very high temperatures inside these structures, it's a whole different dynamic than what we're experiencing. Other things, if we start to see things, changes in gait, their speech or behavior, their alertness starts to drop, their orientation changes, and any abnormal vital signs, we're going to want to consider what our options are. And there's going to need to be some sort of a protocol or procedure set up that allows the medics to basically say, no, this firefighter cannot go back in. So there should be protocols in place, because the time to debate whether or not a firefighter can or cannot go back in is not when we're sitting there on the scene of the fire. It should be yes or no, and that's that. We also have a number of caustic substances and caustic agents, such as acids and alkalis. We know when we're talking pH, acids are very low on the scale, alkalis very high on the scale. And when they come into contact with the body, they tend to have some pretty negative side effects. The further away from the body's pH that those substances are, the quicker and more severe they are going to be to react. So things that are very close to the body's pH, take for example water, has very little reaction with our body. But something like hydrochloric acid or caustic lye starts to dissolve our bodies. So exposures can result in all kinds of different results depending on the substance itself. Is it in a more of a gaseous form? Is it giving off vapors? Is it in a liquid form, a powdered form? We can have injuries really anywhere. Eyes, skin, inhalation, sometimes even through ingestion, something like somebody swallowing a battery. All right, sometimes chemicals will get used in an attempt for a suicide. I got to say, in my experience, it's fairly rare. We don't often see people who are trying to, drink a bottle of cleaner in order to try to kill themselves, but it does happen from time to time. So some examples of caustic household agents might be cleaning agents. I've already brought up lye. Bleach is another one that would be very caustic. Your various hydrocarbons such as gasoline, many of your like engine cleaner parts or brake cleaners would have some pretty radical effects. You might have certain other solvents around the house that would have some pretty ugly side effects. So the strong acids and alkalis on the skin strong acids on the skin cause a coagulation necrosis, where it actually starts to bunch up and gather up the material and cause it to break apart there. A significant ingestion of acid would cause a metabolic acidosis, so you add more acid to the stomach, it shifts the overall body's pH into an acidotic state, and it's not from the respiratory drive, it's from the innards. So strong alkalis will cause a liquefaction necrosis, or basically cause your skin to start dripping off and falling off. And then if ingested, acids and alkalis can erode through the esophagus and the stomach, cause a very severe hemorrhage, very severe pain as it starts to continue to eat away at the other abdominal contents. So we do not induce vomiting in patients with caustic ingestion. If it burned on the way down, it burned on the way up. What's damaged in there is damaged. So some signs or symptoms of a caustic substance poisoning. Well, obviously a strong history where they're able to tell us that this has happened. Patients that are complaining of irritation and burning, burns around the mouth and tongue, drooling, hematemesis, where they're vomiting blood, stridor, hoarseness, difficulty breathing, because remember the respiratory drive, or respiratory tract, shares space with the gastrointestinal tract, and that in the form of the pharynx. So it's a good idea to be very cautious as we're approaching these people. Don't expose yourself to any of this. Remove anything that's contaminated, because if it's burning on the inside, there's a good chance it's going to burn on the outside as well. So there's a probability that if they spilled it on their clothes, or they have it trapped between their ring or their watch or their necklace and their body, it's going to continue to cause damage. Flush. So be flushing anything off the skin that we can, and of course out of the eyes with copious amounts of water, and use only water to remove this as much as possible. It's recommended that we flush for at least 20 minutes to make sure that we've gotten everything removed that we possibly can. Activated charcoal is not indicated. It will not work. You can go ahead and contact poison control and medical direction. Airway management can be very complicated. Remember, part of the contraindications to some of our cuffed tubes is that we not use them in caustic ingestion, simply for the fact that we trap some of that substance against the wall of the esophagus or the pharynx. By trapping it there, we actually cause it to stall and cause a lot of burns. It can also be caustic enough to start to dissolve parts of the airway, or the airway device, I should say, the adjunct. Non-visualized airways are going to be contraindicated. So paramedics should be called for this, so they can put in an endotracheal tube or do a cricothyrotomy as necessary. There's a lot of concentrated caustic substances in industrial settings, depending on the setting. But most industrial settings are using varieties of agents as catalysts in the production of their product. Maybe they're etching glass, or maybe they're cleaning metals, or maybe it's part of their refrigerant. There's all kinds of things that you're potentially running into. As some services become more and more proactive in trying to pinpoint those potential dangers in their communities and in their response areas, they're making contact with some of these companies and saying, okay, so we can be prepared ahead of time. What sorts of chemicals might we encounter? So we can get copies of the MSDS sheets, so we can know, where are these stored and where are the areas that could be particularly high risk, high danger zones. And we've already talked about that. Hydrocarbons. Hydrocarbons are many times a petroleum-based product. Things such as kerosene, gasoline, mineral oils, spray paints, lubricants, aerosol propellants. All of these have various hydrocarbons or fluorocarbons in them, and they commonly are used in huffing. So huffing is when people are inhaling these substances with the intent of becoming intoxicated. The thing about it is there is no real defined point level of intoxication with these things. So it's not like you can take a breath test for alcohol and that identifies you as, oh yes, you're intoxicated, or no, you're not. So this again goes on and talks about a lot of the potential substances, but lighter fluids, laundry stain removers, spray lubricants, glues, aerosol propellants, compressed air. Kids are using the compressed or canned air that you use to clean your keyboards and whatnot with, thinking that it's completely harmless because it says air on it. But yet there's that propellant in there that gives them the feel-good feelings of being high. Well, that propellant is actually a very, very dangerous propellant. As long as it's used in a well-ventilated environment, it's relatively harmless. But once it's very confined and then specifically inhaled into the respiratory tract, it has the potential to kill. Hydrocarbons can expose through any route. They can be ingested, they can be absorbed. Gasoline easily absorbs through your skin. They can be huffed or inhaled. They can be injected. Injected is probably one of the least common ways that you would see hydrocarbons introduced to somebody, unless it was an intentional poisoning of some sort. Most people would not inject it specifically into their body. So toxicity and symptoms are going to vary based off of their route, and their amount of exposure. So it's very very wide open toxidrome. That's the sort of things that you're going to see. Typically, the effects it has on the nervous system include an altered mental status, sometimes leading to unresponsiveness. Could potentially be apnea, dizziness, confusion, or ataxia. Most of the time they're getting that kind of a high feeling off of it. I think most of us can relate that we've smelled a number of these things, and some of them really don't smell too bad. Some people do like the smell of things like gasoline, where other people find it pretty offensive. So I think people can somewhat relate. Cardiovascular can cause hypotension, can cause sudden cardiac arrest, can cause asphyxia that leads to cardiac arrest, of course. Gastrointestinally, it's going to affect the stomach and the intestines. Many of these are actually a caustic agent as well, and these caustic agents can start to eat away at some of those linings. Will typically cause some nausea, vomiting, that can be diarrhea, burning of the oropharynx. The exposure to the skin can cause some reddening of the skin, some dermatitis. It can also cause burns, because a lot of these obviously are flammable subjects. Liquid forms of hydrocarbons at a high risk of aspiration, leading us to have a quickly altered mental status and lose control of our own airway, sucking in some of our own vomitus, leading to pneumonias, pneumonitis, dyspneas, hypoxias, and so on and so forth. And huffing is the deliberate inhalation of those hydrocarbons for the purpose of intoxication. Symptoms are very focused on the respiratory system and the neurologic system, although that certainly can extend to other parts like cardiovascular. The most common complaints would include, or signs and symptoms would include, wheezing, tachypnea, shortness of breath, hypotension, and sometimes evidence of the substance on or around the patient's airway. So as they show the picture in the textbook on 736, the one we saw a little earlier in hydrocarbons here, where the guy's got the gold colored spray paint around his mouth there that he's sprayed into the bag. Just an interesting factoid there. The metallic colors of spray paint are the ones that are preferred by the huffers. Evidently there's a little bit extra propellant in there. It takes a little more to propel those specific colors, and so it's a bigger, better high for them. And so the golds and the silvers and the coppers and whatnot tend to be their favorites. So they can also develop some erythema and have dried paint, maybe a present around their mouth and nose. You may also look for a bag that they've huffed from. The one major huffing incident that I responded to, the person was actually driving around huffing gold spray paint from a Walmart bag, and hit a car, killed somebody, and then walked away. As he walked away, he dropped his cans of spray paint, and a little while later he dropped his bag. But nonetheless, once we found the kid, and he'd actually walked to somebody's house not far from the accident scene, and we had gotten called there for an injured party, once we arrived at the scene, we noted the presence of overspray of gold spray paint on his arms and on his face. And before long, the deputies come up and were investigating and telling us that they had found cans of gold spray paint in a Walmart bag that the paint had been sprayed into and huffed out of. A lot of times they also have a very chemical odor on their mouth or on their breath. There is a such thing as sudden sniffing death syndrome, where it starts to really sensitize the myocardium, and it becomes very susceptible to the effects of catecholamine, and it actually throws them into an overdrive, eventually causing them to go into basically a sudden cardiac death. So monitoring cardiac rhythm is a good idea if you can. Otherwise, paramedics are probably going to do that. So again, it talks about some commonly abused substances for huffing: gasoline, kerosene, spray paint, paint thinner, gun cleaner, typewriter correction fluid or whiteout, glues, particularly model glues and airplane glues, some of the more commonly used, as well as the spray air, or I'm sorry, the canned air. Organophosphates, we mentioned this earlier in the chapter. It's found in many of the pesticides. Some of the weapons of terrorism and mass destruction actually employ different organophosphates. Exposure can be from various routes, typically inhalation, absorption, and ingestion. Probably seen more commonly in those people involved in agriculture. They're the ones that use the most pesticides and therefore can have a greater risk of having a significant exposure to those. Sometimes when they're out spraying, if they're not using the appropriate protection, they end up getting exposed simply from the process of spraying their plants. So I've had that happen a time or two, where I picked up a farmer who had, out in an agricultural setting, had hooked up these sprayers to spray some various pesticides. Had been out in the field all day, came in, basically went to bed feeling, so-so, and his wife woke up in the middle of the night complaining that he was thrashing around or had violent behavior or was urinating and defecating in the bed, so on and so forth. Organophosphates are potent cholinergics, and if you remember, cholinergics make you excrete. So, and they produce very prolonged, unopposed stimulation of the parasympathetic nervous system, which makes you sleepy. It inhibits your acetylcholinesterase, so it kind of has a similar to a paralytic effect in some occasions. And we generally use sludge or sludgem in order to help identify the toxidrome. So salivation, lacrimation, so that's tearing, urination, defecation, which is loss of your bowel, gastric distress or complaining of nausea and upset stomach, emesis, so they're vomiting, and then M is the meiosis, in which you have the pupil dilation. So all of this kind of plays in with some bronchospasm and some pulmonary edema. Usually also leads to bradycardia because you're resting and digesting. So that's where we'll get some of this. Sometimes it's even a twitchiness to their body. It looks almost like a seizure. So limit your exposure. Decontaminate the patient as best as possible. So get them stripped down. Get them irrigated with copious amounts of water. Use some soap if available before we start transporting them. Remember, if they just have these fumes of organophosphate coming off of them during the entire transport, and you have a 10, 15, 20-minute transport, you yourself are being exposed to that organophosphate. Airway management can be very complicated. We're going to have lots of bronchial and oral secretions, so suction is going to be absolute necessary. Some services have the antidote kits available. I've mentioned that either the Mark I or the Mark 1 or duodote antidote kits can be used for organophosphate. Depends on protocol, depends on scope of practice, on whether or not you can use those on patients, or they're only used for you and your coworkers. So both of those carry atropine and pralidoxine. Both of them are intended to dry these patients up. The problem is a lot of times it takes more drugs than we have on hand in order to actually get them dried up. So, we may have 3 or 4 or 5 antidote kits on the truck. We might need all of those for simply one patient. All right. In 1995, a religious sect, the Aum Shinriko, used sarin to poison people on the Tokyo subway, and it was a nerve agent. And that nerve agent has also been used in battle, notably in Iraq in the 80s. And chemical weapons obviously still are a huge concern. Many of those chemical weapons are organophosphates. Ethanol and toxic alcohols. All alcohols actually are toxic. It's just a matter of the type and the amount that the person is exposed to. So ethanol, that is our beverage alcohol. It's grain alcohol. It's what we typically in the United States use for our primary intoxicating substance, our feel-good adult beverage. It is a CNS depressant, including a mood depressant, although sometimes it makes us feel a little lighter initially before taking in too much that starts to throw us into the more depressed state. Typically, we see people with slurred speech, ataxic gait, poor coordination, nystagmus, where it's just twitching the eyes, altered mental status, behavioral changes, loss of good judgment, severe alcohol intoxication. Then once we've gone over the edge, we now are dealing with respiratory depression, emesis, potential for aspiration because of the mental status changes, leading to unconsciousness. Probably the number one patient population to pick up with acute alcohol intoxication poisoning are people that are 21 years and 1 day old. So people that went out on their 21st birthday and really tied it on, and next thing you know, they've gone too far, went too much. So don't assume that the only problem is acute alcohol intoxication. Many times other substances are involved. Sometimes people are started on a new medication that has some CNS depressant abilities to it, and then they decide they're going to go out and have a good time, and what normally would be no problem for them to have 1 or 2 drinks has now become way too much for them. There's an increased sense of risk of injury because of some of the lack of good judgment. They have decreased sensation of pain. They're not as concerned with what's going on. We're going to go ahead and check blood glucose because it is an altered mental status. People who have been tying one on for a long period of time certainly have the potential to burn off a little too much sugar, and that can compound their problem of intoxication. We've already talked about in the previous chapter some long-term abuse effects such as Wernicke's and Korsakoff's. Wernicke's is an acute thing, Korsakoff's is chronic, in which they have alterations in mental status. Basically, Wernicke's is an intoxicated appearance, even though they're not intoxicated. Korsakoff's is long-term brain damage. It's been associated with thiamine deficiency, and Korsakoff's is a permanent neurologic damage. So they can have amnesia, they can confabulate things or create their own memory, basically, that didn't really happen. Additionally, they can have some cardiomyopathies. They've been chronically dehydrated, can cause some hypertension because it has some vasoconstriction. May have high cholesterol that may or may not be directly affected with the alcohol as much as it is with their lifestyle choices. Pancreatitis is huge in chronic alcoholics, which can lead to diabetes, stomach cancers, cirrhosis of the liver, damages the blood clotting factors because many of those are created in the stomach, which if we have problems with chronic vomiting and potentially having some ulcers, that can affect that. This one alone should be enough of a wake-up call for many people to not have chronic alcoholism. In males, you can suffer from testicular atrophy, which then causes you to feminize. So you start to develop moobs or man boobs and start to have loss of some of your secondary sex characteristics. You can attempt to verbally calm down intoxicated patients, although I think most of us are probably very aware of how well that does or does not work. Remember, you cannot reason with them, so your best bet is to just try to work with them and get them to get on your side. So delirium tremens or DTs, I mentioned that in the previous chapter, usually about 2 to 3 days following their cessation of alcohol. When they have a history of dependence, then they start to have some of these withdrawal symptoms that include things like seizures and alterations in mental status, tachycardias and hypertensions and sweating, delusions, hallucinations, and so they will get these DTs. Seizures are another big one that come from coming down off of their alcohol dependence. It has a mortality rate of 5 to 15%. A lot of these people will have seizures and potentially aspirate. Talked about that. Got to treat these patients cautiously. They can be erratic and very violent. They're in a state of hyperactivity on the metabolic side, so fevers and whatnot can be in place. They may have extreme tachycardias. Getting them too riled up can actually end up causing them to have some dysrhythmias. And alcoholics are preoccupied with obtaining and using their drug. You don't want to get in the way of them getting their alcohol. We have other toxic alcohols that can cause very severe illnesses, such as methanol, which is wood alcohol. So as wood is starting to break down and becoming basically a sugar, which is alcohol are sugar molecules, but as it starts to ferment, the wood alcohol is methanol. It's used in commercial products, and it's illegally produced alcoholic drinks. It should not be ingested. It actually causes a lot of very, very ugly effects on the body. Things that include methanol might be things that are like de-icing solutions, and then some certain types of cleaners may have methanols in them. But they're very flammable, they're very dangerous, and in some cases also found in meth labs. So patients that are exposed to methanol, say those people, anybody who watches Moonshiners, this is one of the concerns that they have, that they're producing methanol. But if they have it can cause blindness or blurry or cloud vision. It's very common of methanol poisoning. Abdominal pain, nausea and vomiting, altered mental status including coma, and tachypnea. So we're going to need to be very supportive in our management. Start an IV. They have the potential to become hypotensive, so fluid therapy as necessary to support what's going on with them. Maintain their renal perfusion, because renal failure is a very high possibility in patients with methanol poisonings. So it's something that giving them lots of fluid can be very beneficial, because it helps flush the kidneys out. It flushes the system, it flushes the kidneys. Yes, the kidneys do work a little harder, but they don't do quite as much filtering as they do just dumping. They do more dumping and letting some of that stuff out. So it actually ends up benefiting the kidneys. Isopropanol, this is rubbing alcohol, used as a disinfectant. It's what we use in most cases when we're going to start an IV. It's an isopropanol alcohol prep wipe. It causes the standard intoxication effects, the mental status, the ataxia, slurred speech, abnormal behavior, but the effect is twice as drunk, twice as sick, twice as long. So this is usually extremely high alcohol content in here. So things with hand sanitizer, mouthwash, ointments, cold medications, they're very readily available, and many forms of them are actually very cheap. So people can get their hands on them. Even if they have a hard time getting a bottle of booze, they can get their hands on isopropanol. It can also cause severe abdominal pain and GI bleeds. Again, very, very much a supportive cares thing. Respiratory depression, hypotension, dysrhythmias. Ethylene glycol. Ethylene glycol is what we typically find in most antifreezes for our vehicles. It is very lethal in very small amounts. It used to be very sweet tasting. I believe the newer versions of it, they've done some stuff to give some bittering agents to try to discourage creatures from drinking it. Remember, a lot of the older ethylene glycol, a lot of the older antifreezes was a pretty green color, and that pretty green color looked like a lot of childhood drinks that kids were getting, juices and Kool-Aids and whatnot. The new one, I don't think they've done a much better job of making it not look appealing, because now it's orange, but supposedly it's much more bitter and not nearly as tasteful as it used to be in the past. It can be very, very hard on your pets as well. So causes neurologic changes, so the unconsciousness, ataxia, slurred speech, seizures, tachypnea, tachycardia, nausea, vomiting. Risk of renal failure. It is very hard on your kidneys, so again, some fluids can be beneficial to help flush this from the patient's body. Manage the airway. It's again all supportive. So looking for airway support, ventilatory support. So factors in pediatric poisonings include things such as curiosity. So an underdeveloped sense of taste, so they may think, oh, that doesn't taste so bad. An inability to recognize the consequences, sometimes poor supervision or poor child proofing. So there's a compounding problem here that presents better chances for people to become, or for kids to become ill from poisoning. Geriatric poisonings tend to be more things along the lines of multiple medications and changes in cognitive function, or even poor judgment and eyesight, simply for the fact that they're trying to do what they think is right. They may not remember they already took their meds, or they may confuse some of their meds. Maybe they're supposed to take one pill twice a day and a different pill 4 times a day, and they mix those up. Which one is which? That's the reason why so many of them end up with the little pill sorters that kind of give us headaches, because we don't know what the heck the pills are. Food toxins. So there's several different types of food toxins. We've already talked about the first one, botulism. And the toxins that it produces are very, very poisonous and considered to be some of the most lethal toxins in the world. And they happen in many cases in canned foods that were maybe inappropriately prepared. Some seafoods have some dangerous toxins, such as the ciguatera, or the ciguatoxin. I believe that one was